And we have our next speaker, Dr. Gunjan, who's been very kindly taking us through this whole process today. Dr. Gunjan Saluja is a consultant in strabismus, oculoplasty, and neuro-ophthalmology at the Bhatia Advanced Eye Center in Bhilai, Chhattisgarh. She's a colleague of mine. She's also done her MD and her senior residency from RPC AIMS, and very well published author, more than 50 publications, many awards to her credit. I'm going to hand it over to Dr. Gunjan now.
Thank you, ma'am, for that introduction. And I would like to talk about the management of sebaceous gland carcinoma, which constitutes around 0.6 to 10.2% of all the eyelid tumors. It's a highly malignant, potentially lethal tumor of lid, which has high recurrence rates and has a tendency for local spread with a mortality rate of 2 to 10%. It is on an increasing incidence, and it has now become, as reported in literature, it is one of the most common malignancy in India, which constitutes around 33%. Usually presents at around 6th to 7th decade, and periocular radiation remains a risk factor. Other associations like immunosuppression, familial retinoblastoma, HIV virus, HPV virus, and Muir-Torre syndrome remain the predisposing factor. One very important feature of the sebaceous gland carcinoma is that it can present itself in various forms, like in patients with recurrent chalazion posterior blepharitis, superior limbic keratoconjunctivitis, or keratitis. Here in the right below, we can see the picture of a patient. He had underwent IND for chalazion at an outside center, and within 2 weeks had presented with such a fulminant mass. So it's important to rule out whether it's a chalazion or whether it's a malignancy first, based on the classic features like loss of lashes, and sometimes a firm painless nodule or an indurated thickening of the lid. When you evert the lid, you can see the multinodular protruding fungating mass. Sometimes a persistent unilateral blepharoconjunctivitis can be the only clinical feature. Fornical shrinkage because of the diffuse involvement of the palpebral uh, conjunctiva or bulbar conjunctiva can give rise to entropion also. And in late stages, one can have invasion of cornea and orbital tissues. Looking at the classic histopathological features, they can be either well differentiated or highly undifferentiated. The well differentiated forms, as shown in the figure, they are foamy sebocyte like cells with vacuolation of the cytoplasm, and where the vacuoles are usually located in the center of lobules. Poorly differentiated tumors, on the contrary, are basophilic. They are pleomorphic with prominent nucleoli and have high number of mitotic figures. Special stains used are oil red O and Sudan black. Coming to the TNM staging of sebaceous gland carcinoma, the T1 stage means if the tumor is less than 10 millimeters. The T2 stage means when the tumor is between 10 to 20 millimeters. And the T3 stage is anywhere between 20 to 30 millimeters, as we can see in the figures above. Besides this, the T1, 2, and 3 are further subdivided into A, B, and C, depending upon the invasion of the tarsal plate. Coming to the nodes N. So N0 means there is no regional lymph node metastasis. N1 means involvement of ipsilateral regional lymph node. The size should be of the lymph node is less than 3 centimeters. And N2 is involvement of the lid, involvement of the regional lymph node, which is more than 3 centimeters in its greatest dimension. And further, it can be A or B, depending upon the imaging, whether you have done an imaging or whether they are histopathologically proven. So the standard management of sebaceous gland carcinoma remains surgical excision with frozen section. However, the facility of frozen section is not available in most of the places. And in those cases, a wide local excision with 3 to 5 millimeters of surgical margins with delayed closure that should be done within 48 hours is the preferred choice. The reconstruction can be done depending upon the size of the defect. However, one important thing to remember in sebaceous gland carcinoma is that because the carcinoma originates mainly from the tarsus, sometimes dividing the interior and posterior lamella, and then excising selectively the posterior lamella with a wide local excision, and then the reconstruction of the posterior lamella with mucous membrane graft remains an option. Another thing which is important besides lymphatic spread is the pegytoid spread. The tendency for pegytoid spread of sebaceous gland carcinoma has to be not taken lightly. and it has to be ruled out in all the cases. It has to be taken from 17 sites, as has been shown in the figure. If the involvement is up to 1 quadrant, then therapies like cryo can be helpful. However, if there is multifocal involvement in more than 1 quadrant, then mitomycin C drops, plaque brachytherapy, or surgical excision can be chosen. Now, lymph node involvement, preauricular lymph nodes are quite commonly involved. PET scan, being a non-invasive method, is now preferred. Sentinel lymph node biopsy should be done in all the patients who have a tumor of more than 10 millimeters, canthal involvement, anterior orbital involvement, and it helps in early diagnosis of lymphatic invasion. Lymphatic invasion, once diagnosed, should be managed either by neck dissection, radiotherapy, or adjuvant chemotherapy. The role of radiotherapy usually comes when cases of advanced cases with local regional lymph node metastasis or tumors which otherwise require more invasive procedures, tumors with canthal involvement, patients who are undergoing orbital exenteration with histopathological evidence of periosteal or bony invasion, incomplete excision, or systemic spread. Neo-adjuvant chemotherapy, the indications almost remain the same. However, in my experience, neo-adjuvant chemotherapy is much better option. Cisplatin and 5-fluorouracil are the drugs of choice, given in 3 cycles at 3 weekly intervals. Important thing to remember is to do an echocardiography before starting cisplatin in the cases, because it's a cardiotoxic drug. Neo-adjuvant chemotherapy allows local resection of the advanced tumors, and this is one of the sequential reduction in tumor size with chemotherapy in one of my patients, where the patient had presented with a large mass, the large lymph node, ipsilateral lymph node. And first, the incision biopsy was done. Once proven that it was sebaceous gland carcinoma, this was the picture after first chemotherapy, then further it reduced after second, and after third, the mass had drastically reduced and lymph node was not palpable. So according to the management algorithm, which I usually follow, is first of all, biopsy has to be done, whether excision or incision, depending upon the size of the tumor. Rule out lymph node metastasis and peritoid spread in all the cases. Now, if the tumor size is less than 10 mm, go for a wide local excision plus frozen section or a delayed closure, whatever is feasible. In T2 stage, if it is 10 to 20, again, if the lymph node is absent on PET scan, then go for wide local excision plus frozen. If the lymph node is present, then go for a neo-adjuvant therapy. My preference is a chemotherapy, followed by a wide local excision. And if in T3 stage, if the lymph node is absent or present, irrespective of that, go for a neo-adjuvant therapy first, so as to make your life easier while you are reconstructing, and then go for a wide local excision. Always remember, in any kind of sebaceous gland carcinoma or any lid tumor for that per se, never go behind saving the tissue. One has to get rid of the tumor cells, and that should be the main aim. Thank you.
Excellent, Gunjan. Excellent. It was a beautiful overview and very well summarized.
Thank you, ma'am.